Hi, everybody. I want to welcome all of you and thank you for joining us this morning for this MJHS Hospice and Palliative Care Vet to Vet Café. We really have unwavering gratitude to all veterans near and far. Thank you all for your service, and I thank all of you for joining, whether or not you're veterans. My name is Toby Weiss, and I'm the AVP of Cultural Diversity at MJHS Hospice and Palliative Care. And I'm very proud of our membership, MJHS's membership in the NHPCO, which stands for National Hospice and Palliative Care Organization, the We Honor Veterans program. And we've been part of that since its inception in 2010. Today's program will shed light on some considerations around the evolving changes facing the VA. I want to give a shout out to Ashton Stewart, our rock star, as I call him. He's our MJHS Hospice Veteran Liaison and Outreach Coordinator. I want to thank you, Ashton, for pulling the star-studded panel together. And I want to thank our star-studded panel, Commissioner James Hendon, Dr. Joan McInerney, and Mr. Benjamin Pomerance for making time to join us today. Today's program would not be possible without support from TD Bank and from the MJHS Foundation, both vital in enabling us to implement veteran programming and initiatives. And since I see Jessica Benson in the audience, I will also say that one of the programs and initiatives that we provide to our veterans is supported by her or provided by her, which is virtual reality intervention. So thank you, Jessica. And now I turn it over to Ashton.
Thank you so much, Toby. It's an honor and a privilege to be part of the MJHS team and working under your leadership. And yes, the panel that we've got here today, I'm so deeply grateful for your time. Just a few housekeeping items before we begin. We are recording this program today, so if you're not comfortable being part of that, please make sure your camera's off and your microphone is off. And we'd also ask you to mute your microphones for the program as well, just to eliminate some background noise. There's many questions around this program today and about the VA's plan for our VA hospitals and healthcare system. And we've got a few questions that we've prepared today that are seeming to be at the top of the list that we will address. And we know that you have questions as well. So we want you to share your questions with us in the chat. And we will have a Q&A portion toward the end of the program that starts at 12:15. So we will address those questions then. So please know that your questions will be answered today. And also, finally, we have a 4-question survey. We're going to do a 4-question survey at the beginning and at the end of the program because we want to know where you stand. We want to know what your opinion is because it's very important to us. So it's a real quick survey. Just take a few seconds. Rosie, thank you if you wouldn't mind posting that. And without further ado, let's just go with the introduction. On July 27th, 2022, U.S. Senator Manchin announced that the Asset and Infrastructure Review Commission, the AIR Commission, will not move forward, therefore putting the brakes on a much contested plan to overhaul the VA's healthcare system. This decision was reached with bipartisan support from 12 of the 18 members of the Senate Veterans Affairs Committee, also known as SVAC, who had been tasked with approving the commission and its nominees as outlined in the VA Mission Act. This announcement took place just 10 days after the New York City Council Committee on Veterans held a public hearing on this very issue. Passionate testimony was received from over a dozen veterans and representatives from prominent VSOs and the New York City Department of Veterans Services. While this is a priority issue for many veterans and VSO leaders and a priority for many elected officials at all levels of government, today's program is completely apolitical. We have brought together an esteemed panel of experts to help us better understand what the Mission Act means to the VA healthcare, where we currently are in the process, and what we should expect moving forward. We are very grateful for our panelists who are joining us today. They are the best advocates for all things veteran in New York City and New York State, and their work transcends well beyond the borders of the Empire State. James Hendon, Commissioner of the New York City Department of Veteran Services, he's joining us today. And before entering the civilian workforce, Hendon spent 7 years in the U.S. Army on active duty infantry as an infantry officer, where he deployed as a mortar platoon leader and battalion public affairs officer to Iraq, worked as an admissions officer for West Point, and served as a senior advisor to the Afghan border police in Afghanistan. After his military service, Hendon served as director for the NYU Veterans Future Lab, a small business incubator for practicing and aspiring entrepreneurs who are U.S. military veterans or veterans' spouses. A veteran entrepreneur himself, James was also the CEO of Energy Economic Development Corporation, an organization that helps communities and small businesses take advantage of energy-related advancements. Hendon is a 2002 graduate of West Point, a 2012 graduate of Harvard Kennedy School and Columbia Business School, and a 2015 graduate of the Earth Institute's program in conservation and environmental sustainability. We also have Benjamin Pomerance, Esquire, the Deputy Director for Program Development and Training for the New York State Division of Veterans Services. In this role, he supervises the division's appellate unit and all of the division's training efforts, serves as the agency's legislative liaison, and leads several of the division's programming initiatives. His work focuses on advocacy and assistance for veterans, service members, and military families on a wide variety of legal issues, from disability compensation to discharge upgrades and access to healthcare. Benjamin graduated as the salutatorian of his class from Albany Law School in 2013, where he founded and directed the school's Veterans Rights Pro Bono Project, for which he received the President's Pro Bono Service Award from the New York State Bar Association. He has published articles in journals at over a dozen law schools, co-authored a chapter on veteran treatment courts about the intersection between veterans law and mental health services that was published in 2019, and is a true expert in all things veteran related. Also joining our program a little later is Dr. Joan McInerney, who is the Network Director, VISN 2 for the VA in New York and New Jersey. And I'll give a more formal introduction for Dr. McInerney when she joins us closer to 11:45. So let's start. The Mission Act, the acronym stands for Maintaining Internal Systems and Strengthening Integrated Outside Networks. Veterans are afraid right now of losing their healthcare, one of the driving concerns in today's conversation. So how does the VA's Mission Act impact access to healthcare? And we're going to start with Commissioner Hendon. You've got 2 minutes. We're going to time these questions, so please, floor is yours, sir.
Goodness, wish I had a little more time. This is so dense. First off, just want to start by thanking Ashton, to you, Toby, Rosie, and the team at MJHS for making this possible, and my colleagues at New York State Division of Veteran Services. I'd go deeper, but we don't have much time. For Mission Act, I think this is a lot to pack in a small amount of time, so I'm going to try my best here. And I want to preface by saying I'm not an employee of the VA. I'm not with the federal government. I work at a city agency, so I'm speaking from my expertise just from that vein. So to be clear, I'm not the VA when I say this. When I look at Mission, I think the goal there was to make it so that for every veteran who is eligible for VA healthcare, that they could be able to receive that care in a way that is timely, that is close, of high quality, that it befits their health condition, that it's culturally competent and appropriately resourced. I want to say that again. It's timely, close, high quality, befitting the health condition, culturally competent, and appropriately resourced. And so when we look at Mission and we think about these two major planks of it, one being Veteran Community Care Program, it used to be called Veterans Choice. And we look at the other as far as the Air Commission, which you spoke to before, about the realignment of VA facilities. When I think about air, the community overall felt that it would be a net loss to us with going through the air process as far as reducing the VA's physical footprint, that would mean we'd see a reduction when we look at these different metrics I just mentioned: timely, close, high quality, befitting of the health condition, culturally competent, and appropriately resourced. And we saw a disconnect there from the veteran community, and it was also echoed by the elected officials as well, including our New York delegation. And so I think about that as far as Mission. When I think about the Veteran Community Care Program, the issue there has been the appropriately resourced part has led to this tension between making sure that if a veteran wants certain services on the private side, that there are enough resources there for the VA to appropriately fund that. And so we've got this break where there are veterans who are saying, look, the VA will say, hey, we've helped millions of people be able to take advantage of this. Yeah, veterans saying, yeah, but I wasn't one of those people. A lot of folks haven't received that assistance. And it goes to this resource disconnect. I believe that the PACT Act and its recent passage will help to greenlight more funding being put forth so you can see more of the resources being able to be brought to bear to help veterans who want to take advantage of those options in the private sector. I believe that.
Thank you, Commissioner Hendon. Benjamin, let's get your opinion from the state perspective on this question.
Sure. Well, first of all, just to echo the commissioner, I'm honored to be here, and to echo Toby, Ashton is a rock star, as we all know. So great to be here in a program that he is moderating. When it comes to the VA Mission Act, I've been in this space since 2013, and it seemed like when the Mission Act came out, it was in many ways, and I still think it is in many ways, the answer to a prayer and many prayers that people have put forward around, hey, we have to have the following changes take place to VA healthcare. Community care, which the commissioner mentioned, is a huge piece to this. VA choice was a first step. It was a first step that seems good on paper. In actuality, in my opinion, it did not work for a variety of reasons. Reason number one being providers were not getting paid in a timely fashion, so they lost interest, many of them, in being in that network, and also in the community care offices themselves at individual VA facilities. There seemed to be a disconnect between statutory text and implementation of the choice program. So the community care program built in a couple of things that choice did not, both of which I think are great. One is looking at drive time as opposed to mileage. Okay, the community care mission program says you can get care at the VA's expense in the community if the care is not available at a VA facility within a 30-minute drive time for primary care or a 60-minute drive time for specialty care. Those of you who recall choice, recall that it was mileage. Many of you are in New York City. We know that in New York City and Long Island and many other places, mileage and drive time or travel time are two very different things. So a more realistic approach here. Also, there is a provision through Mission where if your appointment wait time is unreasonable, 20 days for primary care or mental health care, 28 days for specialty care,
15 seconds
you have
left.
the ability to receive community-based care as well. And the ability to get telehealth across state lines is also important. But as we know, there's often the difference between what the law says and what rolls out into the individualized basis, like the commissioner said, and that brings us here this morning.
Thank you very much, Benjamin. Second question, there's so much to unpack here. I realize that, so thank you for allowing us to move to the second question. The VA Air Commission states that the next phase in the rollout of the Mission Act is to build new facilities in areas with greater demand to ensure that the infrastructure that makes up the VA in the decades ahead reflects the needs of 21st century veterans, not the needs and challenges of a healthcare system that was built in many cases 80 years ago. So what would the proposed new facilities, when would they be built, and when would these new facilities be operational? And this time we'll start with you, Benjamin.
Well, this is what the Air Commission was looking at, right? And this is probably what brings us here this morning as well. If you look at the VISN 2 report from the Air Commission, it's 82 pages addressing that question. And I will not go through all 82 pages here, I promise. But one of the important things that we have to look at, and the Air Commission highlighted this, and veterans themselves have highlighted this for as long as I've been in this line of work, a lot of these facilities are aging out. We're looking at facilities, when we look at Bath, New York, for example, there's buildings in the Bath campus going back to 1877. There's buildings in Canandaigua going back to the 1890s. And if we look at the facilities in New York City, many of them are not exactly that new either, between 1923 and 1980 as their construction dates. So if you go through the Air Commission's report, you see what they recommended, right? And we see kind of a patchwork of different ideas, some being moving care out of the VA facilities and contracting with certain respected partners in the community, like NYU Langone, for example. Some looking at actually building a new VA facility and consolidating services in certain areas. We see that, for example, in Brooklyn, where for years I've heard about the challenges that many veterans face in getting out to the Poly Place area, to the Brooklyn VAMC. So looking at the construction potentially of a new facility out there. But all of that said, it's kind of at a point now where we got to say, wait and see, right? Because that was the Air Commission's report. And then the Air Commission got effectively dissolved, as Ashton said, because there was no one put forward by Congress, and there was a bipartisan agreement to do this as recommended members of that commission going forward. So
15
now
seconds.
It's kind of in that wait space to say, okay, what is the VA's next step going to be, and what are their future recommendations, if any, going to be? The VA Mission Act does say they need to make recommendations and they need to move in that area. And just given the aging infrastructure that we're looking at here, hopefully we'll see those changes take place.
Thank you, Benjamin. Commissioner Hendon.
Yeah, actually, I can't speak to what the VA is going to do as far as where it's going to build, whatever it will build, et cetera. That's beyond my purview. I think that a lot of this comes back though to, what are we doing as far as outreach and making sure our veterans know about the things that are available to them? Because I think that separate from AIR, which Benjamin spoke about, which you all spoken about, there's an ongoing review that occurs of the VA's assets as far as, what are we going to do as far as building out more things here or reducing certain things there. That's separate from AIR. And so in a more of a hyper local way, you see this process occurring really at that VISN level and down to the VA medical centers of, looking at, how many folks are walking through the door using our services? How does that impact what services we offer in this location? And so I'm very bullish, as I was talking about PACT, as far as what that does for us resource wise and how we may be able to get the word out to more veterans about different presumptive conditions they may not have otherwise known about beforehand and taking advantage of those things. And so when I'm thinking about what's to be built and where, I think there's a direct correlation between what is established and what is resourced and who is walking through the doors. So yeah.
Thank you so much. Okay, we got a little bit of extra time here. This is great because this next question, I'm sure we'll take advantage of that extra time. We'll start with you, Commissioner Hendon. Looking ahead, what stakeholders is the VA engaging with at the city and state level in the planning process? What stakeholders should they be looking for looking ahead?
I want to flag too for this question as far as when it comes to whom I know, as far as what I see in my perch, I know that my counterparts here in New York City who run the medical centers in the Bronx and the Harbor Health System, which covers the other boroughs, that they have very much made themselves available to the Veterans Advisory Board as far as appearing at the public hearings we have here on that front. I know that we've had conversations with them, so I know that we're engaging them. I can't speak to other pieces of it, but I would assume that every VA medical system has a community veterans engagement board, and that there's some sort of engagement going on there. I can't speak to it firsthand. I have to assume that there's some sort of VSO input that's accounted for, and that the outreach team from these medical centers is also kind of keeping their ears on the ground on these things. We look here at Harbor Health, we've got Lynn Johnston, you look at Sean Kingston, who does that work in the Bronx. And so, I like to think that these are different modalities through which they're being able to take this feedback. So, yeah.
Excellent. Thank you so much. Benjamin, over to you, sir.
I'm not sure what the VA is doing currently as far as outreach in that area, but I know what I hope. And my hope strongly is that the VA casts the widest net possible in that outreach, and that outreach occur in a way that the VA is not just saying, this is what we are going to do, but in a way where the VA actually solicits and listens carefully to feedback from key stakeholders in this area, be it VSOs, be it CVEB members, be it individuals and veterans-focused not-for-profits, be it people in state and county government, et cetera, right? The whole 9 yards. To really hear from the people who are boots on the ground in these local areas, this is what we're hearing, this is what we want, this is what we need. Because those are the people who are going to have the best firsthand knowledge of these particular geographic areas and these particular regions and these particular healthcare needs in those regions. And so to hear from people in Brooklyn, hey, this is why it's tough to get to Poly Place, or to hear from people out in the Finger Lakes area, hey, this is why we want to see the Rochester outpatient clinic plus up to a greater extent, or et cetera, right? And those are both things that were in the AIR report. There's a lot more of that out there that I think can be talked about and that needs to be talked about. And I think one of the challenges that we saw with the AIR Commission that led to the AIR Commission's ultimate downfall was the messaging that came out about it seemed to kind of come out in dribs and drabs, at least from my vantage points, and not as, okay, let's talk, right? Here's what we're thinking. Let's talk about if we like it, if we don't like it, how it can be revised, how it can be tailored. That's not really what I saw happening with the AIR Commission. And I know that my hope for the future is that the VA kind of takes that lesson back, and in future dialogues about infrastructure and assets, to really engage the communities that are affected by this from day one, from step one, and to incorporate that as much as possible and more than I think they currently have done in any future work in that area. So that's the wish list.
Terrific. Well, thank you both very much. Moving forward to question number 4, a 2018 RAND report noted that there are over 800,000 veterans in New York State, the 5th largest veteran population nationally, half of whom are over 65 years old. Only about 1/2 of New York veterans are enrolled in the VA healthcare system, and of those enrolled, only about 58% visited a New York health facility in 2015. That represents a little more than 1/4 of the total veteran population in New York State who were utilizing the VA. And those statistics seem to jive with the 2022 gross domestic expenditure report from the VA that found that there are almost 165,000 veterans eligible for the VA healthcare in New York City, and with just under 25% who are using the VA healthcare system. So the question is, would it be helpful to have a higher percentage of veterans utilizing the VA healthcare system? And if so, how can that be accomplished? And this is especially important for the disenfranchised veterans. So Benjamin, this one's for you first.
The short answer is yes. It would be helpful in every way imaginable with all the issues we're talking about today to see enrollment increase. I mean, for example, a lot of you are in the New York City metro market for the Veterans Health Administration. A lot of news coverage came out about the Air Commission report and about facility changes recommended in that report. One thing that I didn't see being talked about enough, again, in my opinion, in that reporting, was the fact that the Air Commission highlighted the fact that in the New York City metro market, the enrollment of veterans in the Veterans Healthcare Administration system was projected to decrease by 23%, okay, over the upcoming 10 years, a decrease of 23%. And as Ashton said, it's already below what we'd like to see it be, all right? So definitely, if enrollment goes up, new attention gets paid to those areas where enrollment is going up. I think that's just sort of a natural progression of things. So for all the issues we're talking about today, yes, more enrollment, I think, equals more attention and better things resulting. So how do we get to that point? I think the one-word answer is outreach. Outreach, of course, comes in many forms and covers many areas. And a couple of areas that I think get overlooked that I want to briefly highlight in the time that remains. One is to veterans who are eligible for VA mental health care through the Honor Our Commitment Act. This is a provision of federal law which is available for veterans who have an administrative discharge, even an OTH discharge, if they served in a combat theater, if they were a survivor of military sexual trauma, or if there's someone who in their military service was stateside, but operating unmanned aerial devices in a combat area. These individuals are eligible for mental health and behavioral health care through the VA under this Honor Our Commitment Act. This is a vastly underutilized area of the law. I have had many people over the past couple of years, including VA people themselves in New York State, in certain areas, say it's not even a law. It is a law. It's been around for a while, and it can be and needs to be utilized on behalf of these veterans, making certain we're doing outreach to that population. Another population that we have to take into consideration, absolutely, are women veterans. There have been stories from the not so distant past that have been absolutely horrific stories about the treatment that women veterans have received in certain VA facilities. And I think that the current administration is doing a very good job in looking to course correct and paying more attention to improving that atmosphere in VA facilities. But it's going to take time, and it's going to take the proper outreach to talk about, hey, this is why this is not, quote unquote, your grandfather's VA, right? This is why it's a more inclusive atmosphere. This is how we're making it a safer space, et cetera. So all of that and much, much more needs to go into that outreach bucket. Daily, not just a one-time thing, but a daily outreach approach to help encourage veterans to enroll in VHA care.
Thank you, Benjamin. Over to you, Commissioner Hendon.
Yeah, I'm just doubling down on where Ben is with this, to say it in three different ways. One is, of course, invest in outreach and marketing. Another piece is to, put hands on our new veterans as our folks are coming home, to do our best to identify them so they can stay within the tribe and then take advantage of these different amenities. And another thing is to all of us get in the habit of asking the question, have you served? So in whatever capacity we are in, to always ask this question so we can identify many more of our people to be able to work with them. I got to double down on what you were at, Ashton, with your numbers. It's 24.1% of New York City veterans are using VA healthcare, those who are eligible, 28.3% for New York State, 31.4% for the United States of America. And when you look at that, I'm right with where Ben is. Even if our population is smaller 2 decades from now, that still, if more people use the healthcare, that's still more than enough for us to have either not just this same profile, but even a larger profile of VA healthcare within the state, within the city. And so I think it gets at a deeper issue, which I tell anyone who listens, do we want to pay the real cost of doing right by our veterans? I feel as though this is deeper than just talking to the VA about it. It's really about Congress, and it comes back to us as a society. The VA has the second largest budget in the US government, yet here it is, we're saying that only at best 31.4% of all veterans who are eligible use their services. And I think that's because there's a disincentive for the VA to really market what it's offering. I had someone once tell me, you know, if I put a sign up on the Cross Bronx Expressway, I guarantee you we'd have tons of people come in here, but we don't really have funding for that because that's marketing and that's something we're not investing in. And so I think it's bigger than the people who work at the VA. It's really rebounds right back to us as Americans. Do we want to pay the full cost of doing right by the men and women who serve?
Wow. Really thought-provoking responses. Thank you both so much. Moving on to another question. According to a 2011 study conducted by the RAND Corporation, approximately half of the veteran population in New York would prefer to receive their care from private providers. And according to a 2022 report from the New York City Council Committee on Veterans, over the past decade, the demand for healthcare services among veterans has increased. And to meet this demand, the VA has hired more healthcare professionals to work in its facilities and has expanded its purchase of care from private sector providers for veterans whose needs cannot be met in a VA setting. But referring back to the 2018 RAND study cited earlier, it found that only 2.3% of providers in New York meet all 7 veteran readiness criteria for understanding the needs of this population. In short, there were 17% of the providers that meet 5 of the 7 criteria, but the lower end of the spectrum with the 2.3, they didn't meet 2 of the criteria, which includes familiar with military culture and also screens patients for military and veteran affiliation. So what can be done to ensure that providers in New York are culturally competent to deliver person-centered, trauma-informed care to the entire veteran population? Commissioner Hendon, this one goes to you first.
Yeah, no, Ashton, I want to just level set here. And I have to say, cultural competence is important, but I always tell folks, you know, just leading with your heart is the most important piece of this for anyone who's in this space, who's dealing with veterans, and, you know, just work with our people, you know, as far as don't get in your head so much of thinking, I don't know all the ranks in the Army, I don't understand the nuances of the National Guard, et cetera. And so I don't want to engage. I almost look at it as it's kind of like to just ask the question and begin to put one step in front of the other is the key thing that I want many of our providers to keep in mind. And then we can worry about the rest. Oftentimes folks will take themselves out of the conversation because they put a barrier in front of themselves that should not be there. So I just want to say that. Separately, once you do get into the game, you want to become more proficient at this and get a better handle on it. You know, I'd refer people to, this is, you know, something that the state's got as far as, you know, Ben Pomerantz and the team there and Viviana DeCohen, the director for New York State Division of Veteran Services. Go to the Governor's Challenge website, ny.governors_challenge.com, ny.governors, and then the subtraction sign, challenge.com. Go to the Family, Friends, and Community tab on that website. There's a whole section there about veteran cultural competency training, where there's one link that takes you to Psych Armor, which is an excellent organization that provides different quick classes you can take on your computer to teach you about this. There's another link that takes you to the Military Illness Research, Education, and Clinical Center, or MIREC, to their veteran cultural competency training link. And so those are just some resources, but I want people to just get in their head. It's almost like going to the gym. You know, we got to get you to go to the gym first. And that is to take the first step of engaging our people. Once you're in the gym, then you can figure out how to work out whatever the machines are they're in, which is, okay, now let me try to make myself smarter on these things. And once again, it's ny.governors, then the subtraction sign, challenge.com, click the Friends, Family, and Community tab, and then go to Veteran Cultural Competency.
Awesome. Thank you. Over to you, Benjamin.
So the theme here is the commissioner and I agree on a lot of these points, and this is obviously one of them. Earlier, the commissioner talked about the importance of investment of funding, right, in making certain that we serve veterans and their families the rest of the way. There's also an important investment that needs to take place for those who want to demonstrate that they care about this work and about this population, and that's an investment of time. And that's where I think this cultural competency piece comes into play. everyone's busy, right? Let's start with that. Everyone in every walk of life is busy with what they are doing. But I think that there is an importance that needs to be placed upon military cultural competency in many settings, and the healthcare setting is one of them. And the commissioner mentioned Psych Armor. I think that's one of the best programs you can use for a couple of reasons. Number one, it's free. So it's not any money coming out of your budget to take those online courses that Psych Armor provides. And then secondly, it's asynchronous learning. So you can be at midnight in your pajamas with a pint of ice cream at your side, and you can watch one of their military cultural competency courses. And they are taught by subject matter experts. They are not overly long. They are bite-sized pieces, if you will, and they are valuable information that just can help to connect you with this particular space of work. The biggest concern that I had in that RAND study wasn't even so much the number of medical providers or the percentage of providers that scored low on the military cultural competency categories. It was another part of that same RAND study, which, if I recall it correctly, talked about the low percentage of medical providers who had a particular desire to learn more about that subject. And that was the concerning part. It's okay not to know something about a certain population or a certain group. I got it. That's okay, right? And certainly as a non-veteran myself, it was a learning curve for me coming to work in this field. But if you want to work in this field, and if you have a commitment to serving those who have served, you have to show that commitment through the dedication of time to learn about that population, to become more militarily, culturally competent. And there certainly are resources out there for free. Psych Armor is one of them that you can use to engage with that work on a consistent basis going forward.
Thank you, Benjamin. I would like just to add on that. So Toby put something in the chat and we're on the same page here. July 25th is Hire a Veteran Day. As a veteran myself, I have already expressed how grateful I am for this position, but Veteran Liaison is my title. And I think Veteran Liaisons could be key in a lot of these institutions if they have somebody that's had the experience that better understands the culture and sort of helps guide the staff in this issue. Maybe that would be more effective as well. Moving on, this question is also requiring a little bit of a lead in. When it comes to serious or advanced illness, people prefer to be at home surrounded by loved ones in a familiar environment. Hospice is a kind of care that allows this wish to be fulfilled, and it can be provided alongside veteran benefits that are most often available, but unknown to the veterans and their families. Quote, for those veterans who prefer to receive their care at home, the VA works very closely with community and home hospice agencies to provide that care in a home setting wherever their home may be. And this is a statement found in the VA's geriatrics webpage. And furthermore, 2018, a report from the National Hospice Palliative Care Organization, New York State was rated at number 50 nationally for hospice enrollment. How can hospice providers collaborate with the VA to maximize health resources that are currently available but underutilized and support veterans who wish to be cared for in their own home? This one goes to you first, Benjamin.
I think in some ways, this is exhibit A for all the conversations we've been having about outreach and making certain that information gets out to people who need it. The VHA, the Veterans Health Administration, does have absolutely, as you were saying, Ashton, a robust hospice care program. It's for veterans who have a terminal condition with fewer than 6 months to live and who are no longer seeking treatment for their symptoms other than to ease pain. And also not talked about enough is the fact that the hospice care program through the VA does not have copays. Okay, so if you are enrolled in the Veterans Health Administration system, part of that VHA package is to receive hospice care and to do so when needed and if needed, entirely copay free. Okay, it's part of that benefits package that you get as a healthcare enrollee. And in a broader sense, there's a document on the VA website, which I have connected many veterans to, and it's been a great help for them in their planning, not just with hospice care, but with any type of longer-term home care. And it's a document called the VA Decision Aid for Care at Home or in the Community. And it is a relatively short but extremely useful document that a veteran can complete and, when applicable, with their family by their side to figure out what care options are best for them. Because when we're looking at the Veterans Health Administration, they have a home-based primary care option. They have a skilled home health care option. They have options where you can receive telehealth services in the home, and on and on and on from there. And I really think that document is a wonderful first step planning tool that veterans and, again, where applicable, their family by their side can engage in this together to figure out, okay, what's best? What is the best VA healthcare offering that we should be utilizing here for the care needs that this individual has? And I've, through the years, connected many veterans with that planning process. They've utilized these home-based care options, and they have been extremely satisfied with the care they've received. So kudos to the VA for their work in that area, because I've heard excellent things about the quality of the hospice care and other home-based care that VHA has provided.
Thank you, Benjamin. Over to you, Commissioner Hendon.
I just want to say the question again. So it's, how can hospice providers collaborate with the VA to maximize health resources that are currently available but underutilized in support of veterans who wish to be cared for in their home? I'm going to address my response to the hospice providers. It seems like it's kind of like, what advice do you have for providers? And this is once again me, not as someone who works with VA, but just giving them what I can from what I see. I think one piece of it is, to the providers to align with any organizations that deal with processing claims for our veterans, to make sure that you're tied to the hip with, be it like us, we are accredited at the New York City Department of Veteran Services, accredited by our friends at the State Division of Veteran Services. We have several VSOs that are accredited as well. To kind of just be right next to them, as far as there's a direct line between getting someone their benefits through the Veteran Benefits Administration and opportunities it opens up with the Veterans Health Administration, the National Cemetery Administration. So I almost feel as though this is one, as far as just a strategy suggestion. Another one is, of course, to stay tied into the We Honor Veterans campaign, which is, it's a national hospice provider awareness campaign that's conducted between the National Hospice and Palliative Care Organizations in partnership with VA. That's wehonorveterans.org. wehonorveterans.org, just as something else to kind of touch base with. And then, last but not least, and once again, this is strategic advice to our hospice providers. I think rolling into the outreach as well within what touches you. In other words, I'm providing hospice services to this veteran, and I found out that they have other family members who've served who may not be taking advantage of certain benefits. Let me make sure I connect them as well. Or I have this person, and it looks like their spouse could be great for receiving dependent indemnity compensation. Let me make sure they're taken care of as well. So just to not do things outside of what you already see, but when you see it and it makes sense to be fed into the VA system, to then feed it. Because I think this is a question about having a seat at the table. And I'm thinking about what ways can you be able to have a seat at that table, which would be good for all of our veterans and their families.
Awesome. And just to further elaborate on that, MJHS partners with both the City Department of Veteran Services and the State Division of Veteran Services on this very issue. We are a level 5 provider with We Honor Veterans, and this is such an effective program to get that conversation going, to learn more about the veteran and their service. And sometimes it's a conversation they haven't had since they've served. And then suddenly you have all of these new options. And so, yes, it's a very powerful program. Thank you for bringing it up. One other thing that's really concerning for veterans and hearing that there's a potential of losing their VAs, their medical centers, is the sense of community. Medical centers are just a place where veterans can congregate. They can socialize when they're in the waiting rooms, waiting for an appointment. There's clubhouses. There's all these additional things that are available for vets. And like, what are your thoughts about the proposed closures? And like, even if we were to get the new facilities, like the time between when they're built, and like where would they go? What options do they have? Commissioner Hendon, this is going to go to you first.
Yeah, Ashton, I have to say, existentially, we're talking about what the infrastructure is like for the generations that follow us, not just today, but what follows us. What we have now is built on what Vietnam veterans fought for. What they have is built on what World War I veterans fought on. What they have is, this goes back. I just want to point that out, like big picture, this is what we're talking about. And I think the ball game, when you go beyond just thinking in terms of the Air Commission or whatever this movement is, that movement is, I think it does come back to us getting the bodies, having the actual veterans come and use these services, that will redound to us having more of these things available to us. Every single resource is tapped. And I'll just speak to the New York City market. Whenever a veteran uses the VA health system here in the 5 boroughs, that adds anywhere from $8,000 to $12,000 approximately to the budget of that VA medical center over that year, just from that veteran having gone in and walked through the doors at least once using that system. So you can see with that dynamic how if more veterans use these systems, our VA will have more resources to be able to do more things. And a lot of what we're talking about is, you know, the resources are constrained. What can we do? And I think that outreach is the key to unlocking that problem. So we're not having the discussion about what can we do with what little we have, and instead to be speaking from a position of abundance. And so I just want to be clear about that. And just, this is such a larger dynamic, and this will continue to be a conversation. It has always been this, really going all the way back to, you know, to the Revolutionary War veterans. So yeah.
Awesome. Thank you so much, Commissioner. Over to you, Benjamin.
Definitely, we're looking at the generations past, generations present, generations future. We're seeing this trend that the commissioner talked about, of each generation kind of fighting for that next level of acceptance and that next level of space. I mean, if we look at the Vietnam War generation, for example, and what they endured after they returned home, a lot different than the current scene today when someone comes home from military service. And thankfully, things have gotten a lot better and need to continue in that upward trajectory of getting better and getting better. On the point of where can veterans gather, where can veterans socialize, I think there's a lot of options beyond the VA health center waiting rooms that are out there. And again, I think because generations have fought for and carved out these different niches through the years, I think that there's a lot more than ever at any previous point in history as far as veterans organizations that exist and veterans groups that exist for that specific purpose. One that we have here in New York State that is an extraordinarily valuable group is the Joseph P. Dwyer Peer Support Program, which, as we know now in this current market, this current executive budget, has the ability to be extended truly across every county in New York State. And what I like most about the Dwyer program is the level of inclusiveness in it. It does not matter when you served, where you served, how long you served, combat versus non-combat, character of discharge, all of that goes aside when it comes to Dwyer. And it's, did you serve? Okay, thank you, come on in, right? And that level of inclusiveness, I think, is extraordinary and opens up the door for these types of conversations and social settings that Ashton, you were talking about. And I think the more and more groups that exist, if they follow that format of inclusivity as much as possible, the more we have that, the more opportunities will exist in these types of settings for veterans to have that camaraderie and that dialogue and that opportunity to be together in that shared space with one another.
Thank you so much for that. Thank you so much for that. While we're waiting for Dr. McInerney, who's scheduled to join us any minute now.
She's on.
She's on. Great. Okay. Well, let me give a formal introduction. Scroll back down in my little notes here.
Can you hear me?
Yes, Dr.
Okay,
Joan, Dr. McInerney, thank you so much. I'm just going to read your bio. Thank you so much for taking the time to be with us today. Dr. McInerney was selected as the network director for the New York State, New Jersey VA Healthcare Network, VISN 2, effective May 1st, 2016. VISN 2, otherwise known as the Veterans Integrated Services Network, includes 10 VA medical centers and 59 community-based outpatient clinics in New York and New Jersey that serve over 500,000 veterans. Dr. McInerney is board certified in emergency medicine and internal medicine, and she joined the VA in April 2011 as Chief Medical Officer of VISN 3, where she led clinical innovation efforts, which included integrating new models of care and implementing evidence-based clinical practice. An advocate of lean processes, Dr. McInerney has championed efforts to reduce inefficiencies while improving safety and quality of care across the VISN. Prior to joining the Department of Veteran Affairs, Dr. McInerney was the chairman of emergency medicine at 2 level 1 trauma centers in metropolitan New York for 24 years as an associate professor of clinical emergency medicine, School of Medicine, State University of New York at Stony Brook, and was designated a member of the National Disaster Preparedness and Response Committee of the American College of Emergency Physicians. Dr. McInerney earned an MBA from the Stern School of Business at New York University and an MA degree in Security Studies, Homeland Security and Defense from the Naval Postgraduate School in Montgomery. And without further ado, Dr. McInerney, I know that you have a statement from the VA that you would love to share with us. So thank you so much for being here.
Hi, good morning, Ashton. Thank you so much. And I'm very pleased and honored to be invited to this. And I apologize that I have not a ton of time today. It's August 4th is a busy day. But I'm very pleased to be here. I joined when James Hendon was speaking, and I want to come back to some of his comments. But I was asked to talk about the Air Commission, and I won't call it the Air Commission anymore, and where we were going in the downstate market. So you're probably aware that in 2018, Congress passed the Mission Act, which allowed veterans to go out to community providers if we could not see them within 30 days or if there was a drive time. And part of that bill also required the VA to do an analysis of their facilities and make an assessment as to what should be changed, what should be modernized, what should be expanded. And as you may know, in VISN 3 or VISN 2, our numbers of veterans are decreasing. People are moving south. Young transitioning service members are, come out in North Carolina, South Carolina, and they tend to stay down there, Texas, and they don't come to New York for a variety of reasons, not the least of which is taxes. And so our numbers are not going up. Our World War II veterans are passing on. And so for our facilities, we're not growing facilities, but Congress had asked the VA to do that. And the secretary was then charged to publish the recommendations in the Federal Register as of last January. And then Congress was supposed to appoint, or the president was supposed to appoint, an Air Commission to look at all the recommendations over the course of a year this year, and then an up or down vote as to whether the VA would proceed with that or not. So in the interim, we have a new secretary, Dennis McDonough, who's fabulous and really so veteran-centric and employee-centric as well. And, he looked at the recommendations, and I think he put them in the Federal Register, and then Congress started to look at them, and they were like, wait, no way. A lot of congressmen across the country didn't want to lose a facility, didn't want to lose a CBOC. And I think then they started to realize that perhaps they didn't want to go forward. So they did not appoint the Air Commission, and apparently will not appoint the Air Commission. So all of those recommendations are on pause. But we do need to modernize. And the plan now in the VA is to really look at where we should be in 2035. That gives us a long enough planning range, 12 years, to think about what the VA should look like. So as you're aware, healthcare is changing. A lot of new technologies, new medications, new equipment, and it's an ever-evolving science. And a lot of our facilities are really old. Many of them are 60 years. The average VA facility in the country is 60 years old or more. And they're very tough buildings to adapt to current healthcare, because the electrical systems aren't strong enough. The cabling for computers is not strong enough. The HVAC systems don't support some of the equipment that we have now, the big CAT scans and the MRIs. And, so in order to, let's say, put in an MRI, you have to correct the electrical, you have to correct the HVAC, you have to do a lot of work. And you have to be sure that the facility itself is strong enough to bear the weight of those equipments. So there's a lot of structural things. And I think the VA was really in the mindset of, let's see what we could replace rather than reconstruct. Because if you do 3 projects, it takes 3 times as long. And with regards to our VISN, the recommendations for Manhattan and Brooklyn were not to close them as services to veterans. It was to reorganize what we do, where we do it, how we do it, and perhaps build some right-sized, right-purposed facilities that would support the veterans. We were never leaving the veterans. And somehow that message got jumped on by one or two politicians who took it and ran with it and said, oh my God, we're closing Brooklyn, we're closing Manhattan. And that was never the intent. You know, the thought was that Brooklyn and Manhattan merged administratively many years ago, and but they never really physically merged. So they have two departments of surgery, two departments of this. And so the thought was, what could we move to Manhattan? And what could we move to a perhaps a new facility in Brooklyn, maybe not with inpatient beds, but certainly with the ability to do many outpatient procedures, same-day surgery, primary care, mental health, all of the things that we do now, but to combine some things to Manhattan. So perhaps we'd only have one ICU instead of two ICUs and things like that. So it was to try to get some efficiencies out of the organization. So all of that is on hold now. And I know there's a lot of noise about Staten Island, and we can certainly revisit that. You know, I can't make any promises today, but I just really wanted to give you the background of how this all came about and the poor messaging that really kind of enraged the veterans. And I understand that, but we're certainly not abandoning the veterans. We know that we do a good job with the veterans. I think the veterans like us. And I think the veterans that have gone to the community are not seeing the same services and the same attention and the wraparound services that they need. And so I think there are great opportunities. And so moving forward, and we're in the early phases of deciding as an organization how we're going to do that. We certainly need to get more input from veterans, from veteran service organizations, and from employees, stakeholders, any stakeholders, affiliates. You know, when we did it, we didn't really talk to the medical schools, and there was a reason for that at the time. And we did talk to veterans, but we didn't get a lot of veterans on the call. So we know we have to do a better job of that going forward. And but I just want you to know that we're here for you. We're not looking to go away. And you know, but I just want to emphasize that healthcare is changing. So, you know, for example, we have a sleep lab in Brooklyn, but now most sleep studies can be done at home. And the veteran gets hooked up and gets the equipment and can do it from their own bed. They don't need to come into a hospital overnight to have that done. So just the way healthcare is advancing, we need different right-sized and right-purposed facilities. And that's really what we're looking to do going forward. And it's a long-term plan. It'll go to 2035. And there'll have to obviously be some prioritization as well, because VA can't, you know, replace all 160 something facilities in 1 year. And Congress won't pay for it in 1 year. So, you know, that's where we stand, and I would open it to questions. Unfortunately, our acting director in Manhattan is on his way to vacation, and he wasn't able to join, but you know, he will be having town halls, and we certainly are available to meet with you. But I would throw it out to a couple of questions. I just have till 12 o'clock though.
Great. Well, I know that Commissioner Hendon and Benjamin Pomerantz, we got a city and a state perspective. Commissioner Hendon, would you like to go with your question first? And thank you so much for sharing the point of view from the VA with us, Dr. McInerney.
Okay,
Commissioner
great.
Hendon, take it away.
Hey, Dr. McInerney, thanks so much for being with us.
Nice to
Good
see
you
you.
again too. Yeah. What can we as community members do to unlock more hyperlocal marketing expenditures promoting VA healthcare in New York? I'll say it again. What can we as community members do to unlock more hyperlocal marketing expenditures promoting VA healthcare in New York?
So I think you said it earlier, to convince veterans to use the VA. And I think as we increase our numbers, we are better able to justify some of the programs that, we would like to have. So, we're open for all veterans, and we've had a recent conversation ourselves about where we could market. I think we have so many colleges in New York City and New York State that, that's probably an untapped resource for us. A lot of them have military experience. And
I'm sorry, Dr. McInerney, I appreciate that. I just want to be clear, though, what can we do to help unlock more expenses in that direction? Like, what can we do to help unlock more of that as far as those expenditures?
with regard to expenditures, I mean,
Yeah, just with regard to spending on the marketing, of these services.
well, you can, as the VSOs, you can do that as a city. You can, you've done a great job with the services for veterans and making them feel welcome. I mean, I don't think can take any of your money, so to speak, even in doing a pilot or anything like that. But partnering, we're talking about partnering with some of the bases that are where the service members transition out of the service, and try to capture them early on. And we see the colleges as an untapped resource, but I'm open to other suggestions. I don't know how you're funded and how we could partner specifically, but I would appreciate the offer, and we can certainly talk about it.
Yeah, no, thank you. It's a long-standing offer.
Right.
Whatever we can do to help unlock resources from the VA on this, as well as what we're doing at the city level, we'd be grateful for. That's what I'm trying to convey. So yeah.
I see. Okay. Oh, VA resources. Yeah. I mean, they are talking. The secretary is. They're working on a branding campaign, and and they do a lot of advertising. I had trouble sleeping one night recently, and there were a number of ads on the overnight for suicide prevention and encouraging the services that the VA has and offers. And I do think we can do a better job of advertising or communicating a lot of the services that we have. We did a session yesterday with my own staff, and we had the homeless coordinator. And, it's amazing how many services we have in the homeless program and to support veterans. So.
Thank you so much for that. Benjamin, I know you had a question for Dr. McInerney as well. The floor is yours.
Definitely. And thank you very much for being here and for sharing these thoughts with us, Dr. McInerney. My question deals, going back to the Air Commission, where the central challenge seemed to be one of communication. You had veteran service officers, you had community veteran engagement boards, not-for-profits that are leaders in this space, and other veterans advocates, particularly within VISN 2, which is our focus here today, seem to feel that recommendations on facility closures and openings and combinations and privatization and et cetera were being made without their input. So in the future, as we look at the plans that the VA wants to make of how the VHA structure is going to look by 2035, what can be done on all levels of this process to engage veterans advocates earlier and more often in this process to ensure that their voices are heard, not just in midstream, but really at all phases of this process that you're engaged with?
Well, I think we definitely have to do a stronger job in talking to veterans and working with groups such as yours and this group to really maybe have some focus groups. So what do they see? What do they like? What do they don't like? Where would they like to see the VA in 2035? And, you know, but there are people who, I just give you another example, and that feel that, you know, they are veterans and that they own the VA. And there was one place where everybody agreed to what the change should be, but the veterans, some of them didn't. And it really was for them. It was going to be a wonderful project, you know, and going forward. So I think we maybe have to come up with some ideas and then float them. But we definitely, we didn't run the communication, the interviewing of the veterans. That was done by some consultants, and I will say it wasn't well advertised because there were not huge numbers of people on the call. So, you know, we know who our patients are, and that's really who we should be talking to, I think. And keeping it local, you know, what works for everybody.
Great, thank you for that. And certainly as that rolls out, you can certainly count the New York State Division of Veteran Services on your list of collaborators and help getting the word out and making certain that things are properly understood from the beginning, as opposed to the way things seem to roll out when it came to air, and connecting you with different people who are leaders in this space whose voices deserve to be heard. So thank you for that.
Right. Okay, great.
You have the same commitment from New York City to Dr. McInerney.
Great. Thank you, James. Yeah. I appreciate that. I see one hand up, Rabbi Yehuda Blank.
Yeah. So I'm with a rabbinical organization, but I also deal with faith-based organizations as well. The question is both to you and to the commissioner. Have you thought of reaching out to faith-based leaders in various houses of worship to reach out to their local veterans as to apprise them what the services are, what's available for VA? That's question number one.
Rabbi, yes, on the New York City side, we'll see more of that with us. So it is something that we've made top of mind to kind of tie in with the faith community. So just to let you know that. So yes.
Right. I mean, I work.
New York State is creating a faith-based initiative as well.
Okay.
I've done things with Gil Monroe, so he's a fantastic person. So I think that's just another area of reaching out to the veterans.
Excellent idea. Thank you.
You're welcome. And the other is, you know, I'm listening, and, you know, when you hear that possible closings, or you say Manhattan will have one ICU unit instead of two, or this, whatever issues that you have, how do you promote the VA as being a par excellent facilities with terrific services when you don't have all of that? And that's number one. I mean, I can imagine somebody who lives in Brooklyn would have to travel to Manhattan and vice versa. So, you know, it's good to promote the wonderful things that the VA has, the system has, but how do you promote things when you're so short on the services that are available?
Well, I think the services would just be realigned. I mean, not to say we wouldn't care for patients in Brooklyn, and certainly if someone showed up at the ER, we would absolutely have people there who could handle them. But for ongoing care, if they required, you know, more than emergent care, they probably would be transferred to Manhattan. And but we have not, you know, we're taking a step back now. So we're not committed to any one model at this point. So, you know, that could change. We might do just the opposite. And, but, you know, you have to think about what's going on in New York City. You all live in New York City. You know all the openings of hospitals in Brooklyn. You know that Cornell built a massive 15-story ambulatory building on First Avenue. And Sloan Kettering is going to build a 32-story building. And Columbia Presbyterian is moving up to Westchester. You know, so it's different. So much is ambulatory now. Same day, minimally invasive surgery. And and taking the services a little bit closer to where the veteran lives. But then when they have something really serious, people go to Sloan Kettering on 68th Street. People go up to 168th Street. You know what I'm saying? It's we can't have an ICU on every corner, and that's not just the VA. That's a fact of healthcare, and so I don't think we're moving in any direction that's different than our affiliates.
It'd be a wonderful idea just when you do marketing and promoting is to say that you're part of our system, you're part of our family, and if there are any services that you need that we cannot provide, we will ensure that you get the services
That's
that
a
you
good
need.
point. That's a good point. Yes. And we have the Mission Act. If there's some one thing that we don't provide, and and there are examples of super high-end oncology treatment or things like that, that we have the ability, Congress has given us the ability to provide that to veterans in the community.
I think that's wonderful.
Yeah, good. So it's going to be a continuum of care, and it's exciting times in healthcare. I can tell you that as a physician. The technology and all that we learned for COVID. We learned a lot during COVID, and to look at things a little bit differently. So it's kind of an exciting time for healthcare.
I thank you, Doctor, for your response.
Okay.
And the Commissioner as well.
Okay. Well, I thank Ashton and the Commissioner and Mr. Pomerantz and all who were on the call. I really appreciate it. And I will come back some other time and spend a little more time, but I really have to jump on my noon call.
No problem. Thank you, Dr. McInerney.
All right,
and
good.
You can count on MJHS as a partner as well. We value our work with the VA. And so this was really helpful to have you take part today. So
and thanks to all of you for your service and your continued service on behalf of veterans. So thank you.
Okay, sure.
Bye.
Bye-bye. Okay, well, how about that? Interesting. The plan was not to close, it was to reorganize. And yes, I think this was the messaging concern that Benjamin brought up earlier in the program that kind of got away from everybody. And here we are. And, I saw something recently in a document. It was actually the engineering news record published on July 1st that if the air proposal doesn't resurface in some form, decisions on funding and building new VA hospitals and clinics would continue to rest with Congress, including the Appropriations Committee. So it just seems like Dr. McInerney said, things are in flux and they're taking a step back. But I want to hear from the Commissioner Benjamin. I want to hear your thoughts after hearing what Dr. McInerney had to say. So Benjamin, let's start with you.
Well, I think that when it comes to anything, the air commissioner or anything else, right, it's always easy to sit back and play Monday morning quarterback when you do a postmortem. But that being said, I think that there's a lot of lessons learned from what happened with the Air Commission that all of us in this space, all of us who together make up this community of veterans advocates, can and should take away from what we just heard from Dr. McInerney and what the Air Commission report says, and also what it does not say. And the biggest takeaway, I think, is to when something like this comes out, when some story breaks that something is going to happen, it's to kind of take that proverbial deep breath and to actually go and read the documents in question, right? The Air Commission report for VISN 2, like I mentioned, is 82 pages long. It's not exactly the fastest reading in the world, but it's reassuring reading. Because when you read it, and I read through it once again last night to make certain that I had this correct for today, it talks about, hey, Manhattan, if we can't establish that partnership with NYU Langone that we're talking about, the Manhattan VA stays open, right? Albany, if the Albany VA Medical Center can't establish that new partnership that we're talking about with Albany Med, the Albany VAMC stays status quo, et cetera, right? So it was not anything in there, at least nothing I could see after several readings now, that says facility X is going to close and veterans in area X are going to be stranded. This wasn't there. And yet the messaging that came out from this in many media outlets and many political outlets that was the messaging that they said. Oh, it's closures, and we got to fight to keep these things open, and we got to fight to keep things status quo. I'm not sure as that was the fight in which we needed to engage. Now, do I think the Air Commission recommendations as written in draft number 1 were perfect? Of course not, right? And those of you who know me, and many of you do, know that I'm not an apologist for the VA when I think they're doing something wrong. And I'm happy to bang on the table and do what needs to be done to try and help them course correct. But I don't think this was that time to bang on the table in the way that the banging on the table took place around New York State and elsewhere. And I'm concerned that in some ways, this actually was an opportunity lost. Like I mentioned at the outset, I've heard since 2013 from many veterans across the state and many other states as well, rightful and legitimate concerns about the aging infrastructure of VA medical facilities. And, you know, you're looking at these World War II era and before facilities. Yeah, there needs to be those updates. There needs to be that refresh. And this seemed to be that opportunity with money devoted to it, actual federal dollars, and a plan being put in place that was well-reasoned to make this happen. Again, do I think it was perfect? No. But I think the better response from my vantage point would have been to find ways from the veterans advocacy space to engage with the VA leadership in dialogues around this and to encourage our political representatives to do the same and to try and take draft 1 of that report and have it be built upon and improved into what best reflected the needs of the veterans community in VISN 2, as opposed to, okay, better scratch the entire thing, which is what ended up happening with the Air Commission being effectively dissolved at the Washington, D.C. levels. And so my hope is that we do see this come back around again in some way, shape, or form. My hope is that it comes back around again with the VA approaching it differently in terms of their communication strategy and their outreach strategy. So all the players who are in the veterans community have an opportunity, not after the fact, but at the beginning of the fact, to make their voices heard and to share their opinions about what works best for them, what works best for their areas. And then when reports come out in this build-in toward the 2035 goal that Dr. McInerney talked about, that we actually take the time to not jump to conclusions, take that deep breath, sit back, read the reports, and then after we read, then we can react. So that's sort of my hope for the future. So Ashton, back over to you.
You're on mute, Ashton.
I keep getting muted. I apologize. Commissioner Hendon, what is your take on this new information shared by the VA?
You know, when I think about what Dr. McInerney, her comments, and first off, you know, I echo what Ben said. I think that we've got to have veterans, you know, in the room from the beginning. And I think that was the original sin here, was that we didn't have the veteran community involved from the first steps of this. I think that if we had all been co-creating this, I think we would be in a different place right now here, but that didn't happen. It seemed like a gotcha moment as far as when that first, you know, market review was posted. So I echo everything Ben said. I guess I'm still in the place where when I think about Dr. McInerney's comments, what stays in my mind is I don't feel like there's, I want to say the numbers again, you know, about 24.1% of New York City veterans who are eligible for VA healthcare use it. The number's 28.3% for New York State. It's 31.4% for the United States. I don't feel like at a higher level, leaders in the VA are asking themselves, what can I do to get this number from 24.1% to 100? How can I get it closer? How can I do better here? How can I get this number at the state from 28.3% to 100, and so on and so forth? And I think that, you know, even the initial premise of some things Dr. McInerney said came from, oh, the population is declining, it's declining. And there wasn't a discussion of, you know, what are we doing to make sure all of our veterans know about these benefits in the first place? I tell everyone, I'm a broken record when I say this, we've got people who never served a day in their lives who know what USAA is. How is it that we have veterans for whom it is still a mystery how to access their VA benefits? They're not really made aware of these things, you know? And I think about it, if a tree falls in the woods and no one hears it, does it fall? And to be clear, this isn't just about the Veterans Health Administration. I can give you similar stories regarding the Veteran Benefits Administration, National Cemetery Administration, where the overall issue is, what are we doing to make sure folks know about these benefits and services available to them? Mama Viv, Reverend Viviana DeCohen over at New York State Division of Veteran Services, Ben Pomerantz, myself, and others, we're doing everything we can to get the word out. But it would be great if we also had that same level of intentionality and focus from our folks who are doing this on the federal side, as far as a hyperlocal approach to it. I don't think we have any of these conversations if we have more of our veterans using the healthcare. And to be clear, the argument that, oh, the population declining, even if the population went to where the VA projected to be in 2045, we would still have so many more veterans than the current number of beds being used right now. In other words, even if we are living in a post-draft era veteran population, we still have, just everything within us to be able to get the word out to these folks. They can use these benefits, and we can still have a very robust and fruitful system. And it worries me sometimes that we don't have that conversation.
This is amazing, this conversation. And we're standing by at the ready to work on this issue with you. And the We Honor Veterans is something we touch upon because, again, it's like you talk to these veterans who are at the end of their life and they haven't taken advantage of a lot of the benefits that they've earned and that they're there for them. And it's so hard, and there's so much red tape sometimes to get them to be considered eligible for them. You got to go through all these steps. You got to fill out applications. It should be easier. That's the other issue, of course.
Ashton, so I just want to add this. I want to make sure that folks know this. It's clear. This is, once again, a roughly $300 billion budget for this coming fiscal year, second largest budget in the government, federal government. And it almost seems like there's a situation where if more people use it, then that budget's going to get higher. And so it's almost as if there's an incentive against having that budget become higher. And so it always goes back, and it's not on Dr. McInerney, not on the folks who run the VA centers. It's really a question for us through our Congress. Do we want to pay the full cost of having a man or woman serve? Because if the answer is yes, then we wouldn't have these issues. We wouldn't have this discussion. We would have solved the riddle on this a long time ago, and more of our brothers and sisters would know about what's available to them and would take advantage of it. And so I just feel like that's at the heart of this thing. Yeah.
And that's what we want. We want to go for the heart of it to be effective. I'm so glad that we've had this conversation today to continue this dialogue at a future time. It was really great to hear her offer that. I want to take a second. We're going to do the post poll, which again is only 4 questions for those of us, for those of you still there, please just take a moment to fill it out. We're going to start taking a few of the questions in the chat in order that they came. The first one was about electronic medical records and how they're going to integrate into the public-private sector systems if this continues, this partnership with other private care. Benjamin, we'll start with you. Do you have any answers about that question?
It's obviously a key issue and one that we really need to have a VA leader in the room to answer, because that's going to be on them for themselves internally and also with any technological individuals with whom they contract to figure out what that process is going to be and how that process is going to keep all of the obvious legal concerns, starting with privacy, at the forefront of their operations when it comes to those types of electronic record usage. So we need someone from the VA to answer that one, but certainly it's a topic that is a primary concern in this area, and one that I certainly hope and would assume the VA would say this takes center stage with any type of work in that area.
Yeah.
Commissioner
Hendon, I've got to echo Ben. That's beyond what my wheelhouse as a city veteran services commissioner as far as that particular question. Sorry.
Okay, here's another one for you then, Commissioner. The decrease in attributed to the population of veterans, is it attributed to aging out or lack of awareness? That's a question from Laura.
It's okay. So the veteran population is decreasing, period, in the country. And so when we went from having a draft, when we had the draft, up until I think June 30th, 1973 was the last day we had a draft. And so once we went to an all volunteer force, you saw a decline in the number of people who were serving in the military. Also, we take the same people and deploy them many, many more times as far as this modern military we have, including guardsmen and reservists. We're doing more with contractors as opposed to military service members also in these theaters. And you see just a greater use of technology. So the number of people in the military is declining. And so compared to what it was in the 70s, the 60s, 50s, et cetera. And so that's one piece of this. What's always been an issue is self-identification. where only so many of our veterans will put a hand up and self-identify. And what I'm speaking to is steps we can take to increase the proportion of us who are self-identifying out of those of us who are left, who are still here. To be clear, it's 317,000 is the number of veterans estimated to be in New York State in 2045. As of last fiscal year, it was 208,671 veterans who were using the VA health system in the state. So you have a dynamic where there's still so much room for us, even with a decreasing population, to take advantage of these services and actually grow our usage of them. But those are the dynamics affecting this underneath it all.
Thank you, Commissioner. Benjamin, do you have anything to add to that question?
I definitely think that aging out is a factor. Certainly when you look at the population demographic statewide, we're seeing that the majority of New York State veterans, the largest demographic group of veterans in the state, are age 65 and above. So certainly age plays a role. But I definitely do not think it is the only role, and I think lack of awareness remains something that each and every day all of us as advocates are kind of pushing back against and trying to spread the awareness of what the VHA and the VA overall can provide. And I think that sometimes we think about that only being for the younger veterans, providing that awareness. I have spoken to countless veterans in that age 65 and above demographic over the past 9 years who were not fully aware of what their veterans benefits, be it healthcare, be it financial benefits, be it property tax exemptions, whatever, what those benefits were. There's a presentation that I give quite often to different groups. It's called Mythbusters, kind of like the TV show minus the pyrotechnics. And that's because a large part of our work in this area is a Mythbusters work. It's making certain that we're cutting through the noise, so to speak, and going past the mythology of what somebody is or is not eligible for, and getting to what the law actually says they're eligible or not eligible for. And that's with healthcare, that's with compensation, pension, and everything else we can talk about in the veterans benefit space. So yes, aging out is a factor, but I still think that the awareness campaigns are the predominant focus of what we as veterans advocates can and need to do to increase that VHA enrollment, to increase VA benefits utilization, and to make certain that people are just simply getting what they earn by virtue of service to this country.
Thank you. And in that same vein about awareness, there was a question from Jessica, who was asking what type of outreach is working to attract the youngest veterans?
There's no one-size-fits-all answer, obviously, right? But a couple of things that we are doing at the state that have been quite helpful. One thing that's new this year is we are working in a new capacity with the U.S. Department of Defense to be able to get some data that's quite useful about people who are returning home to New York State, and we are reaching out to them as rapidly as we can with welcome letters, with top-level, information packets, not a big binder, it's not War and Peace, but just basics about, hey, here's what New York State offers to veterans and their families. Here's what the U.S. government can offer. Here's the way we can advocate on your behalf to connect you with these benefits and services. So making certain that when someone is recently returned home, that we're reaching out to them as rapidly as we can. And the commissioner mentioned this earlier, the importance of early contact, right? That first year between military discharge and the end of that 1 year period post-discharge is referred to by many experts in this area as the deadly gap. And it's referred to that in that way because that is a dangerous period and a period of heightened risk in all the negative categories: homelessness, criminal justice involvement, suicide, you name it, right? And so we want to make certain that in any way that we possibly can, we are connecting with those veterans and, if possible, with their families as well, to make them aware as soon as possible about what it is that they have rightfully earned. And then we see some different programs out there that have been very beneficial as well. For example, there's a great collaboration that we have between the state and the city and a couple of excellent organizations in New York City, Black Veterans for Social Justice, for example, and the Campaign Against Hunger. And then in other areas of the state as well, like Western New York Heroes and JCEO of Clinton and Franklin County, focusing on assisting veterans and their families who are facing food insecurity. And that's been kind of a gathering place as well for veterans, and I guess in particular demographically younger veterans who want to do good work together and want to have that sort of unit cohesion concept, getting together and doing good volunteerism work together. And we're seeing a lot of excellent examples of that in New York and nationwide. Team Red, White, and Blue has done a lot of great work in that area as well, finding ways to get together in an active sense And that getting together in an active sense has seemed to have been particularly attractive for the younger demographic of veterans.
Thank you, Benjamin. Commissioner Hendon, do you have anything to add to that? About
Just,
how to
you know, we're happy to work with what Benjamin's doing with the DoD side of it, as far as what New York State DVS is doing. I would encourage folks to also ask the question, you know, once again, have you or a member of your immediate family ever served in the military? If more of us just keep asking this question, and whatever facets we're in, it can get more of our brothers and sisters to come on the net. And then, you know, I want to emphasize influencers as well. You know, it's not just about that veteran. It may be that key person in the veteran's life who is the person who really gets them to make that decision to go embrace these different opportunities and whatnot. And this applies to our young veterans, as far as newly transitioning members, and our older vets. So, yeah.
Thank you so much. We probably have time for one more question. I do apologize that we weren't able to get through all of them. I've just been taking them in order, but this is a dense program and this is a dense topic. So I thank everybody for taking the time to join us today and to start uncovering some of these answers. This last question, has there been any updates to the linkage between two transition assistance programs and VA awareness for soldiers? Also, feel like there is a significant lack in career fair awareness and resume development for exiting soldiers. Commissioner, would you like to address this one first?
I'll start, and mind you, this touches things that are really, when you think about the transition assistance program, it's DOL vets, Department of Labor vets to an extent, and there's some DOD pieces of this. To echo the great work that you know, Director Cohen and Deputy Director Pomerantz, they've been doing at New York State. I know that right now, step one for them is getting the information for those who are transitioning out of the military, those DD-214s right now. I know that step two is going to be obtaining the information for folks who are entering the transition assistance program, so that the state, and hopefully by extension, the cities and municipalities in this state, will be able to put hands on those service members before they get out of the military. And we're hoping that can redound to good opportunities that we share with them on the employment side. Be it for us in New York City, we've got nyc.gov/VetConnectPro for those looking at city jobs and leveraging military connection into that. And then we have on the city job piece, EmpireVets.com for folks looking at jobs in the private sector. And so those are two resources we have for veterans in this space. But we're hoping that we are able to touch base with more of these veterans before they get out and help them in these ways.
Thank you. Over to you, Benjamin.
All fantastic information. In addition to that, another program in which we are engaged here in New York State and are going to remain heavily engaged in New York State is called the ETS Sponsorship Program, which is a nationwide initiative. New York State's been an early adopter of it through our work with the Governor's Challenge to Prevent Suicide Among Veterans and Their Families, like the Commissioner mentioned earlier. And this is a way that we can connect with veterans. We as a state can connect with veterans 6 to 8 months before their ETS date, their date of separation from service, and to connect them with somebody in the area of New York State where they are going to be returning home. And that somebody is a person who has gone through a rigorous training program that the VA has put together in collaboration with the ETS sponsorship group in Washington, D.C., focusing on turning that trained person into a mentor, a sponsor, if you will, who is able to then help that returning veteran navigate that post-discharge life. And in particular, focusing on that first year after separation from service. So connecting them with the right resources for benefits, connecting them with the right resources for education, connecting them with the right resources for employment preferences that veterans are eligible for, et cetera, and so on. And also, you know, to the Commissioner's point earlier about camaraderie, being a friend, right? Being a guide, being someone who can walk that road with them so that veteran's not walking down that path by themselves. And that really needs to be our goal in this particular area that we're talking about, making certain that whatever we are doing as an advocate, it is focused on that sense of togetherness, focused on that sense of making certain that veterans and their families know that they have people who are in that corner with them and walking that road with them, and making certain they realize they do not have to go it alone. You know, these systems can be complex to navigate. Anybody who's ever filed a VA claim knows how complicated that system can be and how complicated the appellate structure can be, et cetera. But there are plenty of resources out there to make certain that no veteran ever has to walk that road alone. And nobody in a veteran's family ever has to walk that road alone. And now we have to make certain, all of us together, that veterans and their families are properly linked up with those resources whenever possible and however possible.
Thank you both very much. I know we've come to the end of we're actually a couple of minutes over. This has been fabulous. Commissioner Hendon, Benjamin Pomerantz, Dr. McInerney, you've made this such a powerful program. I thank you both very much. If you want to take a 30-second closing thought statement, great. If you have to run, I get it. Thank you, everybody who joined us today as well. Commissioner Hendon, do you want to close it out?
Yep, I'm close out with just the bookend of this. You know, if you need to reach us at the New York City Department of Veteran Services, we can be reached at nyc.gov/vets, 212-416-5250, connect@veterans.nyc.gov. The social media handle for us is @NYC Veterans, nyc.gov/vets, 212-416-5250, connect@veterans.nyc.gov, @NYC Veterans. Thank you so much for all who are here today. Yeah.
Thank you so much.
And over here on the state side, it's 1-888-838-7697 is our phone line. www.veterans.ny.gov is our website. And yes, you can book appointments with any of our Veterans Benefits Advisors through that website if desired. And we are doing appointments in office as well as virtually. So if you want to do a conversation with one of our subject matter expert benefits advisors via Teams or Zoom or WebEx, we can absolutely make that happen. And then social media, we're on Facebook, Twitter, Instagram. Our handle is @NewYorkVeterans. Thank you, Ashton, and thank you everyone at MJHS for putting this together. Commissioner Hendon, always a pleasure to be with you. Dr. McInerney, thank you for sharing your insights. And to everyone who's here, thank you very much for taking part in this conversation. Looking forward to more. This really is the Veteran Services village, if you will, and all of us have a role that we can play to make certain that veterans and their families can get what they rightfully have earned. And that really is the beginning and the end of where all this comes from.
Well, cheers. Thank you so much, everybody. Have a great